Our final speaker is Vanessa Peter, who is from Rossdale's, Head of Diagnostic Imaging at Rossdale's. We're running about 10 minutes behind schedule, but I intend we'll just carry on as, and just finish a bit late.
Wonderful, thank you very much for the introduction. I will try to excite you with the factors of Bruce. My screen only shows really small.
We've got a very small screen down here. I don't know what's...
Well, I'll just continue with that and try to keep it as entertaining and as possible. In the meantime, I have no sources of funding competing interests to declare, but I would like to thank my team at Rossdale's. Well, we are very privileged that MRI has become quite readily available to our clients here in the UK and in Europe. Generally, we can divide in two types of acquisition. Low field MRI with a standing sedation protocol versus the general anesthetic with low or high field. To use both systems bear their difficulties. Both systems have some shared factors that influence the image quality, and both of them have individual ones. So we'll just go through it a little bit. I tried to give these 20 minutes a structure by dividing in intrinsic, so machine-related factors, and extrinsic, environment-related factors. Please don't judge too harsh, because a lot of the factors actually are blending into both of those groups. We unfortunately don't get around to not briefly talk about physics, about hard and software processing techniques, and we have to understand that most often it's a big compromise of the duration of acquisition versus the resolution and the contrast. So the points I would like to talk to you about are the resolution, signal-to-noise ratio. I might touch contrast briefly, and some artifacts regarding the intrinsic factors. So the spatial resolution, the resolution is defined by the size of the individual in 2D pixel or in 3D voxel. The smaller the pixel or the voxel size, the greater the resolution. It is very closely related to the field of view. The voxel volume itself is closely related to the field of view, the matrix, and the slice thickness. And I would like to just look quickly at those three things. So the matrix size is actually the number of pixels or voxels within the image. Increasing, therefore, the matrix size will also increase the number of pixels, and that then results, whilst the field of view is staying the same size, a better resolution. So increasing the matrix size increases the spatial resolution, and you can see it here with those squares. The field stays the same, but the little voxels or pixels are becoming smaller. So that's great. The problem is that we have a certain amount of signal available, and the signal decreases the more we divide it into smaller pieces. And unfortunately, it increases our scan time, which then in a practical setting becomes a problem again. So let's have a look at the field of view. Well, the field of view obviously is the size we are looking at, determines the size, the area of to be imaged. A larger field of view means a larger area imaged, means we can cover a greater space over a shorter period of time. The matrix size, though, remains the same. So that means to fill up a larger field of view, the voxels are becoming larger. Therefore, increasing the field of view increases the viewing area, and that increases, the signal increases as well per voxel, but it lowers the resolution. The slice thickness, increasing the slice thickness again means that we have a larger area that can be imaged in a relatively shorter period of time, but again at cost of resolution due to the increase in volume averaging, unfortunately. The slice gap which we can choose is the bigger the slice gap, again, the greater the area that can be imaged. We have less artifacts, but small lesions may literally fall between the gaps, so that is the downside on that. Here I just want to show quickly the comparison between a T1 3D on a low field system with a 3 mm slice thickness versus a T1 3D high res with a 1.5. And you can see quite clearly, even on the big screen here, that we have a very fluffy situation on the left side. There are some enthesiophytes which may well get smoothed over, and the definition of borders of soft tissues may become blurry. So we are losing detail. The same with the T2 fast-spin echo on the left-hand side. Again, a normal T2 fast-spin echo fast on a low-field system with the 5 mm slice thickness, and it's a fluffy story compared to the T2 fast-spin echo high-res with a 3.5 mm slice thickness. Moving on, signal to noise. Well, there is always background noise, we can't get rid of that, but to get a useful picture, the amount of signal from the thing being imaged should be greater than the noise around it. So a higher signal to noise ratio means a better and more useful image. So there is more signal than there is noise. The greater the size of the voxels, the more signal there is per point in the image. So this is improving the signal to noise ratio. However, as we've just discussed a few slides before, a greater voxel means that each point in the image is larger and therefore the resolution is lower. But higher resolution means lower signal to noise, assuming that all other factors remain equal. Number of acquisitions. What we could do is that we just multi-sample. So meaning that we are doubling, as example, the increase in signal. We will have less noise. There will be fewer artifacts due to signal averaging. But if you double, you also double the scan time. So there comes the problem again, because at some point our clients usually need to have a wee. So to summarize, the intrinsic factors, if we want to improve the resolution, we can increase the matrix, decrease the field of view, or decrease the slice thickness. To improve the signal-to-noise ratio, increasing the number of the acquisitions is a possibility, or we have to lower the resolution by, as example, a larger field of view and thicker slices. I don't want to talk too much about contrast. It depends very much on scan parameters. And moving on to the artifacts, there are loads of artifacts, and I will talk about a couple of the practical ones, because if we start going into all the others, we might be here and lunch will be over. So talking about extrinsic factors, the patient preparation, the patient's compliance, and then therefore the movement during the scanning, these are our main concerns. So we always give the horses a settling in phase. That may be because they have traveled for a quite far distance, and we want to let them rest for a moment, to let them urinate, defecate, and feel at home. It could also be that some horses mostly get traveled if they go out competing. So making the horse understand that this here is not about running the fastest or jumping the highest, but rather a relaxed afternoon, that is very important. Getting a clench check, cleaning the sites where we are scanning to avoid susceptibility artifacts is one point, but for me it's also about getting to know my patient. I might be around that horse's hind leg for a while during the scanning, or I might have to positioning a front leg. It's very important to know, is this horse the type of the snatchy type or a fairly relaxed individual? This helps me then also to think about what sedation protocol, as example, I want to use. So that brings me to the scan room itself. Ideally, it's a quiet room and they don't hear other horses walking past. As I mentioned, the sedation protocol can be very individual, depending on what we want to scan, what kind of horse it is, and sometimes also in which country you're based, with availability of and preferences of drugs being used. We want to potentially manage pain, horses which are, so we're expecting from them that they stand super still for 45 minutes or even longer. And if there is pain as an important factor in that horse's situation, placing a nerve block may be really, really helpful. Positioning, again, maybe during the clench check or whilst you were taking off the shoes, you realized that this horse prefers to stand narrow, wide, with the leg underneath itself a little bit more. These are things you need to pick up before scanning so you find the ideal position. I always feel it's better to spend a little moment longer in getting the horse comfortable the way it stands, and then not having to repilot again and start your scanning or being disrupted because the horse is moving whilst we're then actually acquiring. That brings me to the horse handler, often unfortunately very much overlooked, but for me the horse handler is doing a super important job during the scanning and before, and just to create an environment where the horse is as relaxed as possible. Motion correction software, an intrinsic part, but probably for the people who are scanning with low field scanners with standing sedation, one of their best friends, certainly the motion correction software. Respiratory gating, on the other hand, with general anesthesia, may be something that comes in handy to avoid those big movements. The MR operator, also a very, very important person, and I think it starts with simple things. So ideally, the MR operator realizes that, as example, if image quality suddenly is not as good as you would expect it is, or it's declining, then it's important to start very basic and think like, okay, hold on, have I closed all the doors properly? Have I turned off the engine which moves the magnet around? Is maybe my horse holder wearing steel caps in their shoes and is standing right next to the magnet itself? These are the things which sound so basic but are very important. Then the MR operator should know their physics to a certain degree. They should realize what fat suppression, as example, in this situation, to choose the TI length, which can be adapted if you want to fine tweak it. So having someone who recognizes the importance of that is a great, great help. As example, another very good thing to show is phase encoding on fast spin echoes. Depending on what you want to look at and where you might have spotted a lesion whilst you're scanning, you want to flip your phase encoding around. So if you want to look at collateral ligaments, then the phase encoding most certainly is more helpful if it is in a transverse direction. Sorry, struggling here with my pointer. Doesn't matter, you see how the phase encoding is going transverse on the image on the right. There we go. And therefore, we have an uninterrupted field of view of the collateral ligaments. If you're interested in oblique distal median ligaments, you might have to play around and see what gives you the best and freest of artifact image. I will skip those and just come directly to the comparison. This is just an example of suspensory branch and phase encoding. So we all can see this hyperintense T2 fast spin echo lesion within the suspensory branch here. Hold on, it's not a lesion, it's just an artifact, because once we switch the phase encoding around, you can see that the branch is actually having a quite normal appearance. So for me, the operator, a good MR operator, recognizes those things and acts up on it before the horse comes out of the scanner. Sequence selection, Here it goes again very much into the direction of reading your horse. If the horse is not standing super still, you do not need to try to run that stir sagittal as example, because it will not show you anything. Move on, try the sequences which are less motion sensitive as example, and then when your horse is super settled, quickly get all those stirs done as example. Sequence alignment, again, it's very helpful if either you have someone scanning who actually identifies lesions while they're scanning so that sequences can be aligned, or to have a radiologist or someone who's looking at the images, guiding someone through the computer or through messaging that they should check carefully how they're positioning their sequences. So this is just a little simple example of that. We all can see this very large sagittal ridge irregularity and defect here. And if we are transversing through in that fashion, it is very difficult to say how does the border look of that lesion. On the sagittal, we always have volume averaging of the sagittal ridge, so it's not that clear. So you really want to have a really nice transverse through that area of pathology. So if you then turn the transverse around, having it in a horizontal fashion, it gives you already a little bit more detail, but the border is still volume averaging because you have that curve, right? So how it looks when you're actually cutting through an area of pathology perpendicular, it gives you that really crisp margin and much more information. And that is the same if it's a soft tissue pathology or a bone pathology you're looking at. So don't be afraid of moving away from your standard protocol and adding in or replacing certain sequences. Under general anesthesia, it sounds like I've been talking a lot about the horses under sedation, but under general anesthesia, there are also difficulties. Heavy respiration and strong heartbeats can be a problem, so respiratory gating may be helpful, but also the time of examination. Often we are restricted in terms of how we are placing and bedding the horses during those GA MRI scans, and therefore time can be as much of the essence to avoid neuromuscular damage. So I've been whizzing through it. It seems I'm very hungry myself, but to conclude on this, time and motion are certainly our enemies, but do not shy away from high-resolution scans because you make the radiologist's life really much easier the more anatomic detail we can have. The value of an experienced team of operators, handlers, and potentially the radiologist on site is a really great advantage. So I was also, Anne-Marie already mentioned that we were asked to share failures and mistakes, and I can tell you I've done everything wrong. So I've broken coils, I've shifted platforms, I had horses go in the gap behind the magnet. I've done it all. I also had moments where I was chatting away and didn't realize that the sequence was running. And so don't ever feel ashamed or embarrassed. You can be sure I've done the mistakes that can happen with MRI acquisition before. Thank you very much.